Welcome, welcome everyone. Welcome to tonight's Acts 2 workshop, Hospice and Palliative Care Services for older adults with dementia and their family caregivers, what to know and ask. I'm Dr. Rob Glukoff, servant leader of the Acts 2 project and professor, Florida State University College of Medicine. In case you're unfamiliar with the term Acts 2, it stands for African American Alzheimer's Caregiver Training and Support Project 2. Folks, I am very excited about the focus of tonight's workshop. Hospice and palliative care services are key in supporting the quality of life of loved ones with dementia, especially in the late stage of the condition. Unfortunately, many caregivers do not receive information about the wide range of in-home and facility-based services hospice offers. It is also rare for caregivers to hear firsthand from a caregiver peer about their experiences in using hospice and palliative care. For sure, you'll have the inside track tonight. We're going to try to bring it. Audience participants are strongly encouraged to ask questions and provide input during the course of the workshop. Before I introduce this evening's presenters, I want to introduce our partners who have contributed both resources and guidance in the development of the Acts 2 Dementia Caregiver Workshop Series. Acts 2's primary collaborators are the Florida State Primitive Baptist Convention, the African Methodist Episcopal Church's 11th Episcopal District, the Florida General Baptist Convention, the Florida Progressive Missionary and Educational Baptist Convention, and the Florida State University College of Medicine's REACH Project. Turning now to tonight's presenters, we have 4 exciting speakers. At least that's what we hope. We actually have one is having some technological difficulties, but I'm claiming it right now, folks, that we will have 4 exciting speakers. The first speaker is Mrs. Nicole Mccann Davis. The second is hopefully Miss Tracy Wilkinson. Pastor Tracy Mills is third, and the fourth featured presenter is Mrs. Tamika Norton Brown. And I have the distinct privilege of serving as moderator for this evening's workshop. Our first presenter, Nicole Mccann Davis, is Associate Vice President of Health Equity and Access at Seasons Hospice and Palliative Care and Chair of the National Hospice and Palliative Care Organization's Diversity Advisory Council. She holds a certificate in diversity and inclusion leadership from Cornell University, a bachelor's degree in television production from Columbia College, Chicago, a master's of science in communications from Northwest University. And if those weren't sufficient, she's currently pursuing her PhD in health sciences at Northern Illinois University. Nicole was first introduced to hospice as a teenage volunteer. Her interactions with hospice clients and their family members had a huge impact on her. She made it her mission in her daily work, and she does it regularly. Her daily work at Seasons Hospital and Palliative Care is focused on educating about the importance of hospice and to advocate for increased access to end-of-life care for minorities throughout the United States. In Nicole's limited spare time, she enjoys traveling with her husband and family and doing karaoke. Our second presenter, Tracy Mills, is pastor of Collins Chapel, African Methodist Episcopal Church in Baldwin, Florida, and she is outreach program manager of the Community Hospice and Palliative Care Organization headquartered in Jacksonville, Florida. Pastor Tracy obtained her Bachelor's of Arts degree in Administrative Management at Tennessee Wesleyan University and later 2 master's degrees from Liberty University, one in Human Services and a second in Divinity Studies. Her community involvement is extensive. Pastor Tracy currently serves on the Founders Council at Community Hospital and Palliative Care, the Alzheimer's Association Inclusion, Diversity, and Equity Council, and the NAACP Health Initiative. Pastor Tracy's hobbies include singing, writing lyrics, and poetry. Our third presenter, Miss Tracy Wilkinson, has a very close-knit family consisting of her 25-year-old daughter and son-in-law and 5 wonderful grandchildren. She attended Edward Waters College's Accelerated Climb program, focusing on leadership in business and management. Miss Wilkinson has worked in mortuary science for over 20 years and served for 5 years as office director of the James Graham Mortuary Incorporated in Jacksonville. Tracy is also a certified life coach. She now works as a manager of residential living in the Jacksonville-based Job Corps. Note that Ms. Wilkinson has also been highly involved in the Acts 2 project, first participating as a group member when she was a caregiver for her dear mother with dementia, and now as a group facilitator for other caregivers enrolled in the Acts 2 faith-based skills training and support program. Tracy enjoys spending time with family, watching movies, and playing with her grandkids. She is a devoted Christian and dedicated to serving the Lord. Last, Tamika Norton Brown is project coordinator of the Acts 2 project. She has worked in the area of survey development and evaluation for the past 21 years. Tamika has served as a caregiver for her dear aunt and uncle with dementia and has a passion for helping others. Tamika has been a great source of encouragement and support for literally hundreds of family caregivers of older adults with dementia across Florida. She is also a strong leader by example in her church community. During the course of the workshop, I encourage you folks to share questions to be answered after each presentation using the text message function of Facebook Live. We will also have a 15-minute question and answer period following the last presentation. And now we have Nicole Mccann Davis.
Thank you, Dr. Rob, for what an incredible introduction that you provided there. I'm blushing a little bit over here, but I feel so incredibly grateful to be in such amazing company this evening between all of the work that Acts 2 is doing and Pastor Tracy and another Tracy. I'm like, why aren't there 2 Nicoles going on here? But I won't be jealous that we get 2 Tracys and only one Nicole. But I am very excited to be able to join all of you this evening. Once my slides are up, I am happy to dive right in to what exactly hospice is and really how does hospice impact the patient experience as it relates to dementia patients. I think that may be my old deck, but that's okay. We're going to make this work. So, hospice and palliative care services for older adults with dementia and their family caregivers. What to know and what to ask. Let's talk about it. Next slide, please. So oftentimes I like to start off with these presentations really talking about what hospice is and what hospice is not. And so on the slide, on the screen here, you will see what hospice is. And that's important because I know many of us are visual learners. And so I didn't even want to put what hospice isn't on the screen because I don't want for you to see that, but we'll talk through it anyway. And so hospice is centered around establishing partnerships with caregivers. That said, hospice is not about having a team of professionals come in and taking over the care for your loved one. And it's important to note that because that's something that I've heard many times throughout my years working in hospice from different members of the communities where they assume that hospice means, oh, this team comes in, they take over, and that's not what it's about. It's really about establishing those very strong partnerships. Hospice is available to support eligible patients and their families regardless of diagnosis. And it's important to almost say that twice, regardless of diagnosis. And I say that because there are many people who will think that hospice is only for people who have cancer, people who have AIDS, people who have COVID right now. But hospice is really for anyone who has received a prognosis of 6 months or less to live. So it doesn't matter what that prognosis is based off of. If the patient does have dementia, if they have Parkinson's, any sort of disease, if their doctor is referring them because they think that they have 6 months or less to live, then they very well may be eligible for the hospice benefit. Hospice is a benefit covered by Medicare, Medicaid, and most private insurance providers. Now, I don't know about you, but I have certainly had moments throughout my healthcare journey where I'm like, why am I getting another bill, right? You pay for insurance and then you get these bills on the back end. And so I think because of that, it can be challenging sometimes for people to understand that hospice is covered by Medicare, Medicaid, and most private insurance providers without anticipating that they are going to receive a ton of bills afterwards for every little thing. So it can be sort of too good to be true. I think that's the syndrome that we deal with sometimes, thinking that, well, you mean to tell me that this whole team of people come into my home, they provide care for my loved ones or for myself, and that it's covered by Medicare? Yes, that is the case here as it relates to the Medicare hospice benefit. Hospice is flexible according to your needs. We will go into that a little bit more in terms of who makes up the team when it comes to providing hospice care. But it's important to recognize that you can use as many or as few of those services as you would like. And so that is something that we certainly want to take into consideration, that it's really about providing that very much personalized care. Hospice is not a place to stay. And I say that because many times people think, well, I don't want to send my loved one to hospice, but you don't send your loved one to hospice. Now, the majority of hospice patients in the United States, they do receive care in their homes. Most people prefer to die in their homes rather than dying in a hospital. That said, many hospice providers, ourselves included, we do have inpatient centers, which may be in a freestanding building or within a hospital building where perhaps there's a ward or a floor that is dedicated to hospice. And those inpatient centers are not for a hospice eligible patient to go and stay for months and months at a time. However, that is where if someone is experiencing an increased or heightened acute event, then they may go there while their symptoms become a little bit more under control, and then they can go back home. Or an inpatient center may also be used for respite care. And I remember when I first started in hospice and I said, what is respite? What is this respite level of care? And then I learned that respite is really just a fancy way of saying rest or I need a break. And so what I mean by that is sometimes, as I'm sure anyone watching this, anyone who has ever had to care for a loved one understands that caring for a loved one can be a lot of work. And sometimes we just need a day. Sometimes we just need a few days in order to take a look and see, how do I recharge as a caregiver in making sure that my loved one is still being cared for by a trusted team, still having a hospice team to provide all of their needs. But maybe I just need 5 days where I can go on vacation because I haven't been on vacation in a year and a half since I've been caring for my loved one, or anything along those lines. And so respite care is certainly an option that is there. Hospice is provided. Oh, I'm sorry. Can we go back? There we go. Hospice is provided by a team of skilled professionals to support the whole patient. And so it's not just one team member, you get an entire interdisciplinary team, which we will talk about now on the next slide. So the interdisciplinary team, it's important that you are able to understand what that looks like. And so what I love about hospice is that unlike many aspects of healthcare, the patient really is receiving an entire team of people who are there to provide care to them. And so it's not just a house call from a doctor, but instead you have this entire interdisciplinary team. And so we have the physician as one part of the interdisciplinary team, a registered nurse, a social worker who is there to provide those psychosocial or emotional support needs and to address those, because there's a lot that one is working through and processing internally as they are moving along in their hospice journey. We'll say the volunteers are certainly a part of that interdisciplinary team. A volunteer may come by and just sit with you or help to do some light housekeeping or meal prep or brushing one's hair, giving a foot massage, so many things that a volunteer can do. A certified nursing assistant, also called a CNA or a hospice aide, they are there to make sure that they can take care of your personal needs. And so a CNA or hospice aide in this case, they would come and help with bathing, with washing hair, with dressing the patient. Those are the people that really provide a lot of those personal needs and really help to build extremely personal relationships with our patients and families, as do all members of the team. But I just have a soft spot in my heart for hospice aides in particular. Music therapists are also covered by the Medicare hospice benefit as well. And I don't know about you, but music certainly helps to fill my cup and fuel how I operate on a day-to-day basis. And we don't even realize how much music impacts thinking about our dementia patients in particular, those memories that we stay in tune with. And so being able to experience music therapy, having someone come to your home to play music for you live, whether it is, even if English is your second language, music therapists are often trained in playing a variety of music, being able to sing songs in different languages, I mean, every genre you can possibly think of. And I've been able to sit and watch and experience firsthand these music therapy sessions. And it's so incredibly powerful as a way to really make sure that our patients are feeling exactly like who they are, that they are remembering certain lyrics. It never ceases to amaze me. A patient who has dementia or is later on, even if it's not a dementia diagnosis, but how they just connect with music towards the end of life. And then there's also going to be someone who provides spiritual support for the patient and family as well. And I call them spiritual support. However, many hospice organizations will refer to anyone as, they may refer to them as chaplains as well. But I like to say spiritual support because it's important to note that while they're there to help support your spiritual needs, hospice chaplains or hospice spiritual support specialists, depending on which organization you're speaking with, they don't try to force any one specific form of religion on you or religion at all. They will come and pray with you if that's something that you're interested in, that the patient is interested in. However, they're really there just as an additional layer of support. Next slide, please. So what can you expect exactly from the hospice team? This part is incredibly important. So in order to qualify for the hospice benefit, the patient must be assessed first by a hospice clinician and meet specific guidelines for the FAST scale and their comorbidities as well. And so after that assessment is done by the hospice physician, I should say, that is when we can then make sure that the hospice physician and the referring physician both come to an agreement and say, yes, this patient is eligible. And based off of that, then the patient can officially be brought onto hospice services. I like to take questions throughout the presentation. So sorry if I'm throwing off our format, but oh wait, it just went away. Oh, darn. What did it say? Sorry. It popped. Okay. Do you need to have a referral to take advantage of hospice? If so, who can refer? And so hospice is actually, it's very interesting. You do need to have two physicians who agree that the patient is eligible for hospice. That said, you actually can reach out to a hospice provider directly if you'd like, any hospice provider, in order to find out if your loved one or you, if you are the patient, are interested in hospice, and they can give you direction to move forward there. And so you don't necessarily have to have your physician reach out to start that initial connection with a hospice provider. You can do that yourself if there's one that you're interested in. If you go online and you do some research, or if there's someone that's already been referred to you through a family friend who maybe has had their own experience, you are certainly welcome to reach out to a hospice organization yourself. So on the next slide, we are going to, and that was a great question. Thank you for that. We're going to talk about the development of SMART goals when it comes to patients and the caregivers. And so SMART goals, we want for them to be measurable. We want to make sure that we are keeping track of what the goals are of the patient, but also the caregiver. That's something that is so important to note when it comes to hospice care, is that care is there just as much for the caregiver, the family caregivers, or the loved ones who are helping to care for the patient, as it is for the patient itself, which is why the Medicare hospice benefit not only covers the physical and spiritual and emotional needs of the patients, but after the patient dies, their loved ones are eligible to receive bereavement services for 13 months. And so that care, that love, that continues even after the patient has died. But when we talk about the development of SMART goals, it's important that the patient and the caregiver are having opportunities to collaborate with the hospice team. And so when you're developing those goals, everyone should be doing that together. If the patient is able to contribute to that conversation, then that's great. Having a loved one who is there to advocate on behalf of them is always an option as well. But regardless, hospice is very much a collaborative effort, because at the end of the day, the hospice team, they know hospice, they are clinical experts, whether it be in music therapy or social work or nursing, etc. However, you know your loved ones best. And so that's why it's so important that that collaboration is occurring. Hospice also, it's important that when you're developing your SMART goals, that you keep in mind that it's personalized care based on patient and caregiver needs. And so every patient is different. That's why I love hospice so much. It's not about going through and just checking off a box and saying, yep, we're putting this patient in this box. Every person is different, and every person's needs are different, especially at the end of life. It's such a personalized time. And so it's so incredibly important that we are taking into consideration a patient and their family's cultural needs, any previous experiences they may have had with the healthcare system, whatever it takes in order to make sure that we are truly collaborating, that we are meeting the expectations to the best of our abilities, because we die one time. And so it's incredibly important that whatever the patient wants, whatever the family needs in that moment, that the hospice team is there helping to contribute to that. And then the hospice team will also make sure that they are providing safe medication management, providing the family caregiver with the tools, or the patient with the tools, to make sure that medication is being managed, because I know that there are times where that can be a concern for different patients and families, depending on the types of medications that are being prescribed, but ensuring that that is managed safely. And after the patient dies, that medication is being that the medication goes away in the way that is appropriate for the community and for the industry as a whole. Next slide, please. And so what can you expect from your hospice team as well during each visit? So our 4 A's that we have here: every visit, the hospice team they should assess, ask, address, and adjust. And what I mean by that is, it's important that they will come in, they will assess the patient, they will ask about any updates since the last visit or any new challenges that have come up. They should address what they can during that visit. And so while they are there, if you're bringing up new challenges, if there are any new experiences that have come up, any questions that have come up, that they are able to address what they can during that visit, but also understanding that if the visit is with, let's say, a music therapist, they cannot make changes to medication, right? And so they would need to go and have that conversation and document that for the next nursing visit, or call the supervisor to say, hey, we need to get somebody out here a little bit sooner. But that said, they will also make adjustments to meet any new needs that fall within their roles, to make sure that you are receiving the comfort and support that is appropriate and can be provided at that time. Next slide, please. And so my favorite part about doing these presentations is really to talk about caregiver advocacy, because as caregivers, sometimes, we only know what we know, right? And we don't know what we don't know. And so it's important to figure out, how can I advocate for my loved one? And so share with your hospice team how they can best partner with you. If it's important that we don't have certain services, or that we want all of the services, or that my loved one, after a certain time of the day, they're not doing so well, so all of our visits need to be prior to 1 p.m., or whatever that may look like for you, so that it's not making hospice is really there to make your life easier and to add an extra layer of support. And so it's important that you're sharing with your hospice team how they can best partner with you. Share previous experiences with providers that weigh upon you. And when I say that, I mean experiences that weigh upon you positively or negatively as well. Because sometimes a patient has had a wonderful healthcare experience, can be with any healthcare provider. And if it's something that really stuck out to them, it's important that your hospice team know, so that they too can try to replicate that to ensure that the patient is having those really positive experiences. But at the same time, if there are previous healthcare experiences that were perhaps negatively received by the patient, then it's equally as important that you let the hospice team know, so that they can take that into consideration, because we don't want to make the same mistakes if there's something that has been previously experienced. Also, identify a threshold for advanced directive discussions. Not everyone wants to have conversations around advanced directives. Not everyone is comfortable, but it is important to identify when is the right time to have that conversation. If my loved one, or if I am the patient and I realize that, you know what, I don't want to have the conversation now, but let's talk about advanced directives when I can no longer cook for myself, when I can no longer go for walks around the block because that's something that brings me joy. If it seems that, whatever it may be, identifying what that threshold may be and letting your hospice team know that, you know what, right now I'm not ready to have that conversation. However, if we get to this point, then let's bring it up again, and then I'll be ready to have that conversation. And also, as caregivers and as patients, it's important to allow yourself to ask the uncomfortable questions. And I say that because many times people come to me and I see, um, actually, this even speaks to your question, Randall, around should I wait for the doctor to recommend hospice? How would you suggest I ask my physician if they don't seem aware of how much difficulty I'm having? And that's when having those difficult conversations, those uncomfortable questions, are really important. I've had many people come to me over the years, and they're talking to me about their loved one, but their loved one's doctor has not made the recommendation to hospice. And even though it can be uncomfortable, I will tell them, at next time you go with your husband, your mother, whoever it may be, to the doctor, sometimes you have to pull the doctor aside and ask them very directly, would you be surprised if my loved one died within the next year? You can even say year. And if they say yes, do you think that it's time for us to start having conversations around hospice or palliative care as another option as well? And so that directive a question, and it's hard because we want for our physicians to be able to say this is to proactively tell us these things, but not everyone's the most comfortable, to be honest, with having those conversations. And so at times we have to put on the uncomfortable hat and say, I'm going to just ask this question because if there are additional services that I can be receiving to help me and help my loved one, then let's go ahead and get that going. But sometimes we just have to be direct in asking the questions that are so incredibly important. And every single time that I've suggested that someone ask that question, their loved one's clinician has come back and said, no, I would not be surprised. And then they've referred them to hospice. Next slide, please. And so with Seasons Hospice and Palliative Care, which is also an accent care company, we are all across the country, including in the state of Florida. And, I love to talk about everything that we've been doing as an organization for years with our commitment to health equity, which now that is my job. I'm completely over health equity, but it's something that's been going on for many years. And so our motto is to empower one another through understanding. And when I say that, empowering one another really includes the community as a whole, our healthcare partners outside of hospice, but also internally with our own staff. And so what that looks like is doing a ton of education, community education, We love it. I love to be out there with everyone answering questions like Randall's, and working with organizations such as X2, and making sure that more and more people are able to know what hospice is and what hospice isn't, because knowledge truly is power. Our healthcare partners, we do a lot of education through continuing education courses around hospice, because similar to Randall's question, not everyone understands what hospice is, or not everyone may be ready to have that conversation. And that even includes physicians. And so it's important that we are able to also provide additional education to our healthcare partners out in the communities as well, so that they too can understand what hospice is and how it helps to support the whole patient. It's truly holistic care. And then with our staff development, we do a ton of internal education around cultural considerations at the end of life. And it's important that we're doing it consistently, so that it's always at top of mind, that there's always more that we can be doing to provide a better end of life experience that supports the whole patient. I think that's all for this evening for me. If there are any other questions, please feel free to let me know.
Wow, that was one outstanding presentation, and so comprehensive and just so personalized. It was like you were speaking your heart to my heart.
Thank you, Dr. Rob.
I have a couple questions for you, and I'll try to keep them straightforward. Uh, what are the differences in the types of services hospice offers between in-home and facility-based care?
Yes. So in the home, which is where the majority of our patients are, which in the United States, most people want to die in the home. They don't want to die in the hospital. And so you will receive all the services in the home. So when I say all, that includes the social worker, the music therapist, the physician, the nurse. Everyone comes to the house, right? Not all at one time. We are still in a pandemic, but everyone comes to the home to provide care, and that is on an ongoing basis to make sure that patients, that their symptom management is happening, that they're feeling comfortable, that any equipment that is needed for the patient in the home has been ordered and delivered there. The hospice team coordinates all of that. And so I just love that they go ahead and do that. I had one patient that I was speaking to recently with her daughter, and she said, they came to the hospital and they saw mom, and they said, yes, we went ahead and signed her up to hospital or to hospice, and all the hospital bed almost beat us to the house, like everything just got there so quickly. And they absolutely love that. And so, the fact that that was something that they didn't have to worry about, that everything was just taken care of for them, was incredibly important. But when it comes to inpatient centers, which are more so when you are going to a facility, that is for if you're having a high acuity episode of some sort. So your symptom management, your symptoms are very challenging to manage for the time being. A patient is experiencing some acute pain, then for whatever reason, then it may be best to have them go into an inpatient center temporarily. It could be for a day. It may be for a few days, to make sure that the hospice team is there around the clock to care for the patient, versus if a patient is at home, they're not going to be there 24 hours a day. But if they're at an inpatient center, they're able to really address those needs, and really get everything under control, and then they can go back home. That said, respite care, which I mentioned before, you can receive respite is covered, I want to say up to 5 days every month, um, by Medicare, where a loved one maybe just needs that break, and the patient can actually go on respite, which means they go to an inpatient center, they have round the clock care that is being provided there, and their caregiver, their loved one who's been caring for them, can maybe go Christmas shopping, or they can go on vacation, or just lay in bed and stare at the ceiling if that's what you need to do for the day. But that way they know that the patient is being cared for, by the hospice team.
Well, thank you, Nicole. I have another question for you. For persons who are not currently insured, they don't have Medicare or Medicaid. and have listened to Nicole McCann Davis this evening, what would they do now hearing this to help a loved one with dementia who may benefit, maybe is at toward in the later stages, to ensure that when the time comes for hospice, now they're uninsured, what could
Right.
they do to facilitate the possibility of hospice care for for the loved one with who's currently uninsured?
So I would still encourage them to reach out to the hospice organization, because many hospice organizations have charity care, and that's when, they are able to still provide care even if someone does not have insurance. And it's just another reason why I love hospice, to be honest, because I just think that it really takes so much into consideration when we're thinking about the needs of patients and families. And so I would reach out anyway to the local hospice organization. And if they don't offer it, call another one. Like, there are so many that do offer it that I actually don't know of any that don't offer charity care. And so if you had to call more than three, I'd be shocked in order to identify one that offers charity care.
Thank you so much, Nicole. I'm glad we have at least 15 minutes at the end. I have 5 other questions, but I'll spare you that opportunity at this point. And I thank you so much for your thoughtful words and such a sensitive, caring approach to hospice.
Thank you, Dr. Rob.
And now we have our next speaker, Pastor Tracy Mills. We're so excited to have you back again, Pastor Tracy.
Oh, well, I am grateful to be with all of you. Thank you, Dr. Rob and Ms. Tamika and the Acts 2 Project for allowing me to, what I'm going to call, to psychoanalyze my journey and understanding the terms of hospice and dementia, and so that I can get a clear understanding of the song say what's going on or what's going on, and so we can look at this and so I can be clear. So those of you who are watching virtually and I have dialed in, I want to say it's a beautiful day in the neighborhood, and I'm glad you're my virtual neighbor. And I'm talking as if we're having this dialogue in the setting of a Starbucks. Okay, so I'm real relaxed. And as the community outreach program coordinator, program manager, I'm asking myself, how can I connect and educate the community about hospice, about how can I connect and educate the community about dementia and Alzheimer's? How can I connect and educate the community about the Acts 2 project services? How can I, Tracy, talk about something that I am inwardly conflicted with? How can I reach out when I have not reached within? The next slide, please. I'm waiting for the next slide. The next one. Thank you. Well, Community Hospice has served the community for over 40 years, and we are a nonprofit organization. So whether you have Medicaid, Medicare, private insurance, or no insurance, guess what? You will receive the level of care for whatever you are dealing with. For your sickness, we have no special treatment. You will receive excellent care. For those who have prognosis with a lifespan of a year or less, hospice is here. And as Nicole said, we have a team that works with you and is able to service your needs, and not just your needs, your family needs also. We service within the 16 counties of the state of Florida. We provide quality care. Hospice, community hospice is not a place to go, but it's the level of care that we provide. We do offer honoring choices for those. It's all about the conversation. Advanced care planning is a process of understanding and reflecting and discussing your experiences, values, and beliefs in effort to identify how you want to live your life phase when you have a serious life-limiting illness. Next slide, please. So let's talk about it. If I can be my authentic self, I hope you allow me to be my authentic self. The word hospice made my skin crawl, my inner being cringe. But what I understand today is that the cringing and the lack of comfortability with the word hospice or with the word dementia was not based upon what I knew about hospice or what I knew about dementia. The feelings and the emotions and the thoughts were not my own. Did you hear what I just said? I carried these emotions and I carried these feelings inside internally. When people would mention the word hospice, I would feel, the young people said, I'll look at people side-eyed because I just cringe with the word. Hospice and hospice services or dementia are not easily understood, but it is a journey. And the journey to understanding hospice or dementia or chronic illness can be long. The next slide, please. And then as I was preparing for tonight, I had an epiphany. Now, when I said epiphany, I know you thought about Chrisette Michelle. Now I'm just teasing. But I had an epiphany about my fears and my anxiety and my paranoia and my apprehension were not formed due to my personal experience. I was carried on weight that was not mine. But family fears about hospice, family fears about dementia, family fears about chronic illness became my fears. Whatever my family or friends thought about the word hospice or terms about dementia, that became my thought. My thoughts about the word hospice were not based upon my connection with the word, my knowledge, or my experience, but by what I heard from others, in many instances, unreliable sources. And we all know that translating information from one person to the next kind of gets skewed a little bit, get kind of distorted. And it becomes more and more intense. You know how you start telling a story and you say, I fell and I broke my leg. And then the next time you tell the story, it's like, I was jumping up and down, I fell, and I broke my leg. And then by the time you get to the first person, I was running and skipping and hopping. I jumped up and I flipped back and I fell and I broke. That's what happened with a lot of information when we get information from people in reference to talking about things that we're unsure about. So it became kind of ongoing fear. The fear of my mother was projected on myself. The next slide. So the fear that we normally have when we talk about the word hospice, it brings up thoughts and feelings of fear, anxiety, loss. When you say hospice, you think about death and dying. Based on what they see is what you see. In other words, whatever somebody else tells you, whether you see it for yourself or not, you believe it. So what I'm going to do is share a condensed version of a true story of a friend of the family who was terminally ill, who had a son who was 18 years old. This individual found out that she had cancer, and a short time later, she was unable to care for herself. So we presented the idea of hospice, and she finally agreed. So we ended up taking her to hospice, a hospice facility, and made sure that she was settled. Well, we walked into the hospital facility and made sure everything was okay, and we became her family. Well, the next day, we went in. I shouldn't say we went in, but a family member went to visit. And they found that this individual was in enormous pain. Now, only one person was with her. Listen to what I'm about to say. And this person conveyed to the nurse that she was in pain. The nurse came in, and in less than 2 hours, our friend had expired, according to this one individual that was with her. Did you hear what I said? I was not present, but I believed this individual. And because the person blamed hospice, so did I. So I'm asking you, can we just talk? Can we talk? Can we keep it real? The truth of the matter was, our friend waited till the last minute to receive care or assistance. This person taunted me with the idea that hospice was responsible for our friend's death. This was untrue. She would remind me and rehash the story. She would say, I told them that she was in pain. They came in, gave her some pain medicine, and shortly after, she passed. So that was the story that I believe, because I just didn't know no better, because this is a reliable source. This is a family member. That person's belief became my belief. It became my belief, and I was not even present. This is passed down fear that we have about community hospice, or about dementia, or any illness. It's passed down fear, passed down stories, passed down anxiety, passed down. So if I had to say on my own, what is your fear, Tracy, about talking about hospice, talking about dementia, talking about sickness? Tracy, personally, I don't know, because I only have the fear from my mother or father or cousin. Only their fear became my fear. Their thoughts became my thought. What they believe is what I believe, as if I couldn't form my own belief system. Things they said, even though I did not see it, is what I believe. So then when I talk about going out into the community, I can't really connect with the community unless I deal with my own apprehension, my own awartness as far as my vision of community hospice or hospice care or hospice service. The next slide, please. So there is a difference between hearing from others versus knowing for yourself. There's a difference between hearing and knowing. Now that I inquired about hospice and work at community hospice, I understand. I have gained, get this, eyesight and insight to the word hospice. To the word hospice. You know, I did some study a while back, and as I was looking at the word hospice, it comes from the word host. And so host, with community hospice, we have a host of services. And most hospice facilities present a host of services that they're offering the family and the patient. Host is also, hospice comes from the word hospital and hospitality and the word lodge. So therefore, we provide a compassionate care. I gained eyesight and insight into the word hospice, dementia, and caregiving. I gained understanding that hospice provides comfort care, whether he or she is home, at the hospital, nursing home, assisted living facility. If our loved one become ill, we will want them to have comfort care by those who are experts. Listen, can I keep it real? I had to be a caregiver for my twin sister. That's hard work. And sometimes we do things out of a sense of wanting to connect. Even though we might not be equipped to handle the job, why not allow those that are the experts in caregiving or providing the assistance that's needed for your loved one? So I am wondering, why are we not acceptive of receiving care? Why are we not receptive of receiving help and assistance when it's available to you? And comfort care, whether you have Medicaid, Medicare, private care insurance, or no insurance, comfort care is what we provide. Comfort care does not mean that the person or family is giving up, but they have access to a better quality of life than those who choose aggressive end-of-life medical care. Comfort care. Releasing control does not mean you don't have control to make final decisions about when to choose hospice and who provided care. Comfort care is the best care, which happens when we listen first and coordinate with patient, family, friends, and the doctor. Comfort care. So now my epiphany is that all these years I've taken on this fear of a word that I really had no firsthand knowledge of. Generational fear. So now I've released myself of that, and I'm okay now. I'm okay. It's okay to hear and get experiences from others, but it's nothing like knowing for yourself, talking to doctors and those that in the hospice facilities or arena that can educate you and I about hospice itself. Next slide. So then we're going to talk about some myths. Hospice happens at a hospital or a hospice facility. In fact, hospice provided anywhere and everywhere a patient calls home. So most people think you go to a place. Well, your place could be in your home. Your place could be in a nursing facility, a living, assisted living facility. Whatever that place is for you, that's where hospice care can serve you. Myth: once you decide on hospice, you can't go back. Fact is, patient can revoke hospice participation at any time. If you are doing well, you can You can change. Patient, you can revoke your hospice participation at any time. Next slide. Hospice care is only for people with a few days or weeks to live. Fact is, while hospice certainly helps patients and families during a medical crisis, the fullest benefit occurs when pain and symptoms are managed and patients have time to make personal and spiritual connection. And that's what we want to do, provide that connection for you. We want to help you make that connection. We provide the assistance for you and your family. And most people are unaware how we can help the family. We provide benevolent bereavement care. Sometimes the family just needs someone to talk to. Guess what? Hospice provide that. Only a doctor can refer someone for hospice care. It is important for patients and families to know that anyone can make a referral. A family, a clergy, nurse, or others can refer a patient. A friend of mine referred her sister to hospice. Okay, so it could be anyone. But of course, you will have the finalization. Who would make that ultimate decision would be a doctor. Thank you. Next slide, please. Myth. Hospice care ends with the passing of the patient. Well, that's what I talked about. Bereavement or grief support. We have grief support, bereavement that will help you. Mike, I can share an experience with my aunt who passed this year. My aunt passed, and her only daughter had a problem with releasing her mother. Because her mother was ill and been ill for over 20 years. But my cousin, she had a hard time allowing her mother to transition. Well, someone came in, a counselor came in and educated her about the process, the transition, and provided books and materials so that she could read and have a clear understanding. Now, after my cousin read the book, guess what? She was able to release her mother. And it was a wonderful experience for her. Hospice is only for people with cancer. Hospice for patients of any age with prognosis of 6 months or less. Now we have palliative care. That's for those with chronic illness, such as with what I have, MS or heart disease. Palliative care is there to provide and help you manage your medication, he or she, with their medication. And it could be long-term when we talk about palliative care. But as we speak in reference to hospice it's only for people with cancer, it's only for those individuals with a year or less. Reason for admission may include end-stage cancer, dementia, heart disease, lung disease, stroke, or coma. Next slide. Hospice and palliative care are the same. Both provide comfort care during a serious illness. Hospice only begins after the decision to end treatment for a terminal illness, and when it is clear the person will not survive. Palliative care can begin at a diagnosis and happen at the same time as a treatment. They're one and the same, but yet not the same. One and the same, but not the same. Hospice is for possibly short term, but palliative care is for chronic long term. Next slide. Talk about dementia. I found this fascinating. Memory loss always equals dementia. I have memory loss. And sometimes I think, oh God, do I have dementia? If I forget something and I forget the same thing over and over again. Memory loss is not the only symptoms of dementia, and occasionally forgetfulness is not the same as dementia. So those who are worried if you forget something, no, you're okay. I'll pat myself on the shoulder that I'm okay. Only seniors develop dementia. Listen to this. Look at this. Most people with dementia are seniors, but some people develop dementia as early as their 30s. The average age of dementia onset does occur in the senior years. However, in cases of the earliest onset dementia, this age may be drastically reduced. There is as young as the ages of early mid-30s and 40s. Go figure, right? But we assume that dementia is for elderly, and that's not the case. Next slide, please. So, what did I want to say about my journey? My journey it has been long, it's been up and down, but now I'm on a clear road. Why? Because I know that my apprehension, I know that my fears and all my questions I had about having a conversation about hospice, is nothing wrong with it. And I think a lot of times we are afraid to have those discussions. I always say that everybody talks about heaven, but nobody wants to die. So we have to be comfortable with having the discussion with our family, friends, and our loved one. We are to be present, to serve, and turn every opportunity into intentional and relevant encounters to generate worthwhile experiences. Let's operate with a KIT mode that stands for honesty, integrity, and truth. Mode of seeing, caring, and serving. My time is up, and I thank you for yours.
Well, thank you so much, Pastor Tracy Mills. That was such an epiphany for all of us about the importance of truly embracing the challenge of examining our assumptions about the hospice experience and then moving on to a better understanding of what hospice actually means and what it means to us personally. It was a really a moving journey hearing your testimony, and thank you for your openness, your
Yeah.
own personal testimony. Have a question for you.
Okay. I can think I might have an answer for you.
Yeah, obviously you've fully embraced hospice and palliative care services as a vocation, along with being a pastor. Can you share with us what recently has moved you? What has touched your heart and soul? You now are the program manager, outreach program manager for community hospice and palliative care. Anything that you might share that's really led you to fully embrace that this is a vocation that the Lord has given you?
Well, I think for me it is the epiphany that I had, and understanding that that we all are going to transition one way or the other. But the epiphany was that I it's almost like you take on a heavy load and don't know why you're carrying a heavy load. But when you have clarity of what something is, it's almost like you want to learn how you want to drive a car, drive a stick shift, but you don't really know what to do. And once you really learn how to put it in first gear and take and make the transition, then you want to drive everywhere. And that's how I feel right now in reference to me working in community hospice or working with hospice people, individuals, and educating the community. I'm not afraid anymore. I used to educate people afraid, really didn't want to talk about it. I didn't really want to talk about it. I'm like, oh, let's talk about grief, right? I will hide behind grief. I can talk about grief all day long. But now that I'm aware of it, I'm not afraid to talk about hospice. Now I think I'm freed up and whereby I can talk on any subject about hospice and educate the community that it will all be beneficial for all of us to utilize it if our loved ones become ill, if that makes any sense.
Yes, ma'am. Thank you so much, Pastor Tracy. I know that that we have, I believe, Tracy Wilkinson, our the caregiver who is going to be participating in the session, who in our workshop, who's had technological difficulties, available at this point. So we'll shift now. And I thank the Lord for this, that we now have the opportunity to hear from dear Miss Tracy Wilkinson. Welcome, Tracy. We're so glad to have you. Thank you so much for joining us. And I thank the Lord that we have the opportunity to hear from you this evening and your experience as a caregiver of your mom with dementia who received hospice services. Take it away, Miss Wilkinson. You're muted, Tracy.
Yes,
There you
sir.
go.
I'm sorry about that. I must say that during the time that my mom received care from hospice, that hospice was a lifesaver. Um, we pondered on it. We pondered on it, and we pondered on whether we should allow mom to receive hospice. Of course, we heard scary stories about hospice, and rather we should allow mom to receive the service. Um, as a profession, I've been in the funeral industry for over 20 years. And of course, we'd heard, I'd heard horror stories, and my siblings had heard horror stories of hospice and palliative care. And of course, what I've learned in the funeral industry is that families would most times wait until the final stages before inviting hospice in. And when I say that, waiting to the final stages, they would wait until it was too late to allow hospice to step in to even start to help the families. Um, or the final stages of life, maybe stage 4 cancer, before hospice could even step in to even help the family. Um, my mom had dementia, and it had gotten progressively worse. I was her caregiver, and it pained me to even see my mom have to go through anything like that, because dementia is very aggressive. Um, I'm sorry. Um, so when the doctor suggested that we place her in hospice, we were like, no, we're not going to place her in hospice, because COVID was very prevalent. And of course, we were thinking that we're not going to be able to see mom. We couldn't go to the hospitals, and we couldn't go to the facility to see her. And he said, no, she can receive hospice home care. We were like, oh, really? They said, yeah, we could arrange for hospice to come to the house, and she could receive it in the comfort of her own home. And my siblings, my sister and I, we looked at each other and we were like, that's something that we can consider, because our mom was very particular, and she was very peculiar about who could come in her space. And so when they said that, we were like, okay, because number one, we knew that our mom was going to really put up a fight about us taking her from her comfort zone, putting her somewhere else, and her not being familiar with that space, and then her having dementia, and then you're putting her somewhere where she wasn't familiar with. We were going to really have a big problem on our hands. So we didn't want to just make all of these changes at once for her. So we agreed to go through the interviewing process and allow hospice to come in, and we did. So hospice and palliative care, once we said yes, they began to move swiftly. And we were like, wow, we wasn't so aware that they would move so swiftly. And once the Northside team came in, they took care of us like we were family. And we were blown away. I was like, had we known this, we would have been done this. There would have been no hesitation. We would have done this from the first beginning, when we had learned that mom was diagnosed with dementia. I mean, going through the Acts 2 program was a life-saving, it saved my life, because I was drowning in grief, and didn't know what to do, just with her being diagnosed with dementia. And as being the caregiver, I needed care. So the Acts 2 project taught me how to care for myself, and it taught me how to care for her the proper way. But then having hospice on top of that, they cared for the family as well as cared for the recipient. So when hospice came in, the Northside Home Team and Dr. Ruben Smith and the nurse Geraldine Hopper, it was like, wow. So when they came in, I can remember Mom was like, "Who are you?" And they told her, and she said, "Oh." And she said, "You're so sweet." My sister and I, we were holding our breath because we were like, okay, Mom's going to run them clean out of here. She's not going to want to hear it. She's not trying to have it. And she's going to let us have it. She was so warm and so welcoming to them because it was the way that they presented themselves. They didn't come with the white doctor's coats, and they didn't come presenting themselves as they introduced themselves as the doctor and the nurse, and we're going to be able to, we're going to be caring for you. But and they let them know, they didn't say that we're hospice. We're here to take care of you because you're in the final stages of life. They didn't do that. They told us every step. They said, we're going to send you a care kit. And in this care kit, they told us what was in the care kit. And she's going to be to this certain point, and this is what you're going to need. This is what you're going to do. This is her number. And you call us 24 hours a day. This is what you're going to need. Here's what you're going to need to do. Even until Mom's demise, they were there. From the time Mom took her last breath, we called. They came out. They asked us to look at the time. We gave them the time. They were there within a matter of minutes. They allowed us to give Mom her final bath. They didn't act as if they were in a rush. They allowed us to spend those last moments with Mom. They told us to take our time. They were just so caring and so concerned. They treated our mom as if she was their mom. They always came in with a song. They always came in with something warm, not just to say to our mom, but to us. They treated us like they knew that we needed the care. They never did anything with Mom without letting us know what was going on. I never would have thought that hospice and palliative care would have been so caring and so concerned for families. I never would have thought. So I say to people, hospice is not the final stage. It's not. It's the beginning stage. It teaches you how to live and how to move forward once your loved one has gone. Because it leaves a lasting memory, such as I have. And you can too. I can remember every time they came in, they would take their time. They would shampoo Mom's hair. There was nothing that we thought that we needed that hospice didn't give us. From sponge brushes to swab her mouth, to brush her teeth, to shampoo. They would shampoo Mom's hair. They would sing songs of Zion to her. They would read to her. The nurse would crawl up in the bed with her and sing songs to her. I mean, it was just like family. It was like family. And when mom received her wings, they cried. And I know that being in certain professions, you have to sometimes put this hard shell on. But they showed us that they're human and that they connect with families, that it's a ministry for them. And you have to be called and you have to be chosen to walk in that particular field of hospice and palliative care. It takes a special someone to do the work that they do. And I am forever grateful. My family and I are forever grateful for hospice and the way that they took care of our mom. Now, being in the funeral profession, I've seen people walk out of hospice. I have. My mom just wasn't one of them. But I don't regret not a day that she spent with hospice. And we spent some time with hospice, but we didn't wait till the final stage. We didn't wait until there was no hope. We got a chance to enjoy her, and we got a chance to experience what hospice can do, not just for her, but for the family. And every chance we get, we make a donation to hospice because of the love and the concern that they did for our mom. We don't take it lightly. We don't. And from a caregiver's perspective, the way I loved my mom, I'm the baby of 5. And my mom passed on my birthday, my 51st birthday. My mom received her wings. And my mom and I were like 2 peas in a pod. Where you saw one, you saw the other. So from a caregiver's perspective, the love that I shared with my mom was like none other. And I didn't think that the love that I had to give my mom could be matched. Hospice came close. Hospice came really, really close. And I'm not ashamed to say it. So every chance I get, I'm an advocate for Acts 2, and I'm an advocate for hospice and palliative care. And that's all I have to say.
Wow. Thank you so much, Ms. Tracy. You are a great blessing. And thank you for your willingness to share the story, it was so penetrating right to the heart. And I love the way that you were able to illustrate how great joy emerges from great challenges and suffering, which is basically the message of the Christ. And you have conveyed that so well in the context of hospice and the passing of your mom. And I just sense right now that the peace that you feel in having done all that you could possibly do for your mom, and your willingness to allow others to care for her in her time of need, given that you are and were very devoted to her, and what you gained from that as well. That was I gather, from the Lord, a gift from the Lord, and just knowing you a little bit. So I'll stop there. I just wanted to say thank you for your perseverance this evening. We had some technological difficulties, but the victory occurred at the very end here. And just thank you. We do have some questions for you. For the interest of time, I think we're going to move on briefly to Tamika. And I have questions for you that I will ask, and I know others will be giving you affirmations along the way here. There were a few that would come through before, and we will now proceed to Mrs. Tamika Norton Brown, Acts 2 Project Coordinator.
Good evening, everyone. In the interest of time, what I'm going to do is to do a brief overview of our Acts 2 program, because we feel it's most important to spend the time answering any questions that you all may have about the information that you've been given. Next slide, please. Okay. Acts 2, what we are a faith-based skills training and support program for African American caregivers of loved ones with Alzheimer's or dementia. I will preface this by saying that our 12-session program is for African American caregivers, but any person who reaches out to us will be able to receive referrals to resources that are available in their community. We serve the entire state of Florida, and we have 3 primary objectives. The first is to increase dementia awareness and knowledge through presentations and workshops at faith community and elder care venues, as well as through social and print media. Secondly, we provide brief telephone-based problem-solving consultation and referral services to African American caregivers and other stakeholders. And then thirdly, to deliver faith-integrated skills training and support to distressed African American caregivers of older adult with dementia. Next slide, please. Okay. I'm going to give a description of the structure of our program. And as I said before, this relates solely to the 12-session program itself. Our 12-session program includes 7 group skills building, so there are 3 persons in a group, and 5 individual sessions. All sessions are delivered weekly over toll-free telephone by lay pastoral care facilitators. And those lay pastoral care facilitators are basically lay persons from the faith community who have either seen a workshop or a presentation and decided that they would like to be a group leader, or have been nominated by their adjudicatory leaders, and we train them to be able to deliver the 12-session program. In the individual sessions with the facilitators, they will focus on goal setting and problem solving to address the concerns that have been identified by the caregivers. Most caregivers enter the program with 2 or 3 concerns that they would like to work on. And so they get 5 weeks where they actually work one-on-one with their facilitator to address those. Next slide, please. Okay, the contents of our modules. We have 6 major components. The first is the overview of the basic characteristics of the dementias, or what I refer to as Dementia 101. There is relaxation training that's been combined with calming prayer and or meditation. There is also effective thinking about the challenges of caregiving that's coupled with scripture. I will pause here and mention that although we are faith-based, which means that we have woven in the elements such as prayer, faith sharing, scripture reading into the actual 12-session program, we're also ecumenical. So we're open to everyone. Next slide, please. We also have my favorite module. I refer to it as the me time module. So it's building in pleasant daily activities as a guard against emotional distress. So just negotiating, being able to take a walk or to listen to some music. We also have communicating effectively, not only with the care partner with dementia, but with other family members and health professionals. And then we have those effective problem-solving skills through the goal setting. Next slide, please. Okay, and here are some resources, dementia care resources that are available. We have the Alzheimer's Association, the Alzheimer's Foundation of America, the Florida Department of Elder Affairs, the Elder Helpline, the Elder Care Locator, the Alzheimer's Disease Education and Referral Center. Next slide. Next slide, please. Okay. And how can caregivers contact the project? There are multiple ways to contact us. We have a toll-free number. That number is 1-866-778-2724. We have my local to Tallahassee cell phone number, 850-274-4945. And if you're not local to Tallahassee, if you dial that toll-free number, that will route to my cell phone as well. We have my email address, tnnorton@fsu.edu. On our website, www.ax2project.org, there is a button that says contact us. You can hit that button, fill out your information. That will route to my email. And then lastly, we have our Facebook page here where you also can feel free to send a message, and we will make sure to respond to you in that way. What we are going to do is now, because we want to make sure that we answer any questions that you all may have, we're going to bring everyone back up so that we can do the question and answer portion.
Well, let's get the crew aboard here. Pastor Tracy, yeah. Good. Well, thank you everyone for a very comprehensive, informative, and I would say inspiring set of talks. I thank you for your hard work and perseverance with us this evening, all four featured speakers. A question, I have some questions here, but if we have Melissa or Amy, if you're if you have questions or comments you want to share at this point, I'll wait to share my own. Do we have any affirmations that we want to share at this point? Questions? We have an affirmation from Nikisha Raquel. Thank you, Nikisha, for joining us this evening. You are so strong, Miss Wilkinson. Thank you so much for sharing. Alfreda Mathis, affirmation. Thank you, Miss Mathis. Great job. Randall Stevens, very powerful. Thank you so much, Pastor Mills. Sonia Gilliam Graves, beautiful. Thank you, Pastor. We got the Pastor Tracy fan club here, I think.
I told them all to get on with me.
Yeah, yeah. Well, that's any other questions or comments? If not, I have a few questions here for the panel. They may even have questions and comments for one another. All right. So I'm going to proceed, I think, at this point. I wanted to ask you, Mrs. Nicole Mccann Davis, AKA Nicole. Can you tell us more specifically, what are the differences in the kinds of services offered between hospice and palliative care, so that our audience will have a clear understanding of what is palliative and what is hospice care in terms of specific services offered?
Yeah, so actually there's a lot of similarities, Dr. Rob, between hospice and palliative care. They both very much focus on comfort and symptom management. The greatest difference between the two, to be honest, is that with palliative care, you don't have to have a prognosis of 6 months or less to live, versus hospice, you do have to have that prognosis. And so what that means is if a patient is sick and they could use some assistance with symptom management, they would still like to have that assistance with someone and a team of people coming into the home, you can still qualify for palliative care without being terminally ill and put into that specific category.
what are the criteria, just to follow up, Ms. McCann Davis, what are the criteria for referral and services in palliative care from insurance companies, either private or commercial or Medicare?
It's really just a matter of having your clinician make that referral, to be honest, and doing the assessments that are necessary based off of, they will assess for comorbidities, though they will assess for do a physical assessment, but really all of those things will contribute to making that referral for palliative care versus hospice care. Or they may say, you know what, you're not ready for any of these things. And even though I know you didn't ask this, I do think it's so incredibly important to reiterate some very important points that Tracy Squared, I will say, made with both of them, that really spoke to the importance of being able to access services sooner rather than later. The reason being that a great barrier that I see with hospice care and with palliative care is that people think that hospice care is when, someone shows up, they give you some medication, the next day, that's it. And that certainly does not have to be the case. It's not the case, first of all, but certainly, the sooner that you are aware of what these services are that are available to you, the longer your loved ones, the patient, the family, you as a caregiver can be able to take advantage of the additional layers of support. So I just thought it was worth reiterating, because I love that came up with both of you, is just being able to, and I'm looking at Pastor Tracy and I'm looking at Ms. Wilkinson, and being able to just say that was such an important part that just, it deems being repeated.
I have a question for all four of you, and maybe we could start, with Tracy Wilkinson, and then Pastor, and then Tamika. What are the key elements for making hospice and palliative care culturally responsive? And four of you are Black women. What do you think are the critical elements for hospice to do to ensure that it is accessed optimally by the Black community?
Who's going first?
I'll take a stab at it, and then one of the things that I think I'm finding that as I go into the community, we as an African American community, we have to really get over our fear, and we can't discount history, but history does not have to deem our future thoughts on what hospice is, or how it can assist us now. Sometimes we hold on to what has happened, Tuskegee and things of that nature, so tightly that we're not open to see that there's opportunity. There has been advancement as far as technology, medication, how we serve our community, how we serve one another, and sometimes we are closed-minded as to the services that are offered. And because we're so close-minded, we're not even able to have a true vantage point as far as what hospice offer. We know what it doesn't offer, but what about what they do offer? And I think it's more greater as far as what the positive. There's more positive than there is negative. And sometimes we make the negative much larger than the positive. So I think once we deal with our fear, and that's my goal as I go out into the community, I really want to share with the community that we need to have a discussion, a panel discussion, and let's be honest and do that, be authentic in reference to our own personal fears, and some of them are generational fears.
Thank you so much, Pastor. Let's hear from you, Miss Tracy Wilkinson, about what do you think are the key elements in hospice that need to be considered in working with the Black community and bringing it to the Black community more fully than it currently is?
I agree with Pastor Tracy. Fear, getting over the fear. And also we need to do the research for ourselves. Like my family and I did, we had the fear was there because we'd heard so many horror stories, but yet after speaking with the doctor and us doing the research for ourselves, we found that there was more pros than cons. And then once we got in there, we fell in love with it. So a lot of times you hear people talk about it and you hear so much negative, you hear so many negative things about it until when you really get in there, there's so many positive things about it. So I say get over the fear and do the research yourself. We have to learn to do the research for ourselves and block out the noise.
We have a comment from, once again, from Miss Nikisha. Raquel, thank you for being so active in your comments, Miss Raquel. Seeing more, please put it back up again. Seeing more of Acts 2 via flyers, church messages, even media commercials would be ideal. Having families of color share their experiences would be powerful. Yeah, and that's what we're trying to do with one of our foci here was to speak to the lived experiences of caregivers, and that's why it was so critical to hear Tracy Wilkinson. I know also that Tamika Norton Brown has personal experiences with hospice as well, and I don't know if you wanted to share those now, T, or to share how we could best make hospice optimally available and accessible to the Black community and to other minorities.
I'll give you a combo.
You choose which one you want to do first.
I'll intertwine both. As you said, as a person who, and this is a part of my story that's not often talked about. It's not because it's not really what we kind of focus on when we're doing our dementia caregiving. But I've had two experiences with family members going through hospice. I can say that I was blessed in a way that my first experience with hospice was with my younger brother, who was 16 when he was diagnosed with pancreatic cancer. So I've known about hospice for almost 30 years. And because that first experience that we had, how Miss Tracy talked about how they came in and they really became like family to us. I remember the nurse coming in and said, okay, we're all in this together and let's talk about what we need to do to make sure that not only he's taken care of, but that you all are taken care of as well. And so Miss Kathy, the nurse, and Chris, the social worker, became a part of our family. And so I've been exposed very early on, at a young age to hospice. I also dealt with hospice in the end when my aunt was passing from her dementia. And because I had had that exposure before, I was not as afraid, but I had a very close family member to her who fought me every step of the way and did not want hospice to come in because to him, the minute we say hospice, that means okay, that's it, that I'm not going to have her anymore. And so it took a lot of convincing to say, wait a minute, no, she's not going to go until the Lord says that it's her time to go. But while she's here, let's make sure that every service that's available to her, everything that we can do for her comfort and her ease is done. And that is how in our community that we can work to make sure that people are taking advantage. I'm a big one that talks about, take advantage of resources. Resources are available. Take advantage of your resources. So that's why I'm so glad that my good sis Tracy's audio was able to be fixed so that she could share our story. Because as we see more people that look like us, who have the same experience, as us, who come from the same place, grew up in the same hood, have some of the same life experiences, the more we see that, the more we can kind of normalize. There's so much stigma around hospice, around Alzheimer's, around dementia, that it takes somebody being brave enough to stand up and say, look, I went through this and this is what happened and I'm okay on the other side of it, to get other people to be able to say, well, I might not have all the answers, but maybe it's worth me coming to a workshop and getting more information. Or maybe it's worth me calling a toll-free number to get more information. So we just have to keep putting it out there. We have to stand in our own truth, whatever that truth is, and be vulnerable enough to bless other people by our experiences so that they can be helped along their journey.
Thank you so much, Tamika. I know that we're a little bit going over a little bit here. We've gone an hour and a half. I was thinking at this point that if each of you would share a final thought to each other and to the audience, and I just have one or two announcements at the end. Would that seem okay? I know we could spend much more time on this. I think in some ways we're just getting started, but just out of respect for the audience and our presenters' time, one final thought from each of you, please. Would you like to start, Mrs. McCann Davis, with the final thought?
Sure, I'm happy to. First of all, I just want to thank Acts 2 for even having this platform this evening. And when we talk about how do we make progress, how do we get the word out, it's platforms like this that really help to make a difference. We have to talk to each other. And so when we thinking about my final thoughts this evening is just to have those conversations that may be uncomfortable. People don't always want to talk about hospice. They don't always want to talk about planning for death. However, it's important that we have those conversations with each other so that we know what we want, our loved ones know what we want as well, and they don't have to guess. And so I just encourage you to have those very important conversations as families, but also to have them with your healthcare providers as well, so that they too are able to honor what you like as a patient or as a caregiver as well.
Thank you so much. I think just addressing the issue of our anxieties around our own mortality. We've talked about fears, that intergenerational fears that are passed on, but it's so powerful in a way that what you're telling us, Nicole, is that we really need at times to stretch the envelope a little bit, to embrace the anxieties and tensions associated with death and dying, and to have that conversation is so important. Of course, timing to have that kind of conversation is a key factor in when to have it. But I just want to thank you for your sensitivity this evening in recognizing the importance of this topic and the extent to which you've provided affirmations for all of us here in working in this area. I must say, I am a big fan of Nicole McCann Davis.
And I am a big fan of you, Dr. Rob, and Acts 2 in general. I've been telling everyone about it ever since we first started ever since we first connected.
Final thoughts, Pastor Tracy Mills.
Yeah, I think I'm constantly thinking about, how we have to move forward and press forward, move onward while looking upward. That's my thought. Move forward and looking upward. We have to get beyond our fears and our anxieties and what scare us in reference to the term, and be willing to, be stretched. And that's really what it is. We should be uncomfortable in order to become comfortable. I just said something. I need to write it down for my Sunday school. We need to be uncomfortable in order to be comfortable. We have to get out the boat mentality. That's my final thought.
Thank you. Is it all right if I quote you on occasion?
Absolutely.
Thank you. Tracy, dear Tracy Wilkinson, a final thought or thoughts from you, please.
Absolutely. Don't be afraid to talk about death and dying. I can remember a lot of times my mom would want to talk about it, and I would always shun her away. I'm like, oh, Mom, nobody wants to hear that. We don't want to talk about that. And I mean, eventually I had to talk about it, even though she had a pre-need in place for us, where we didn't have to do anything. But there came a time where we really had to talk about it. And unfortunately, it was when she was down on her back. So don't be afraid to talk about death and dying. But also remember, love isn't love until you give it away.
Amen. Thank you. Tamika Norton Brown, final thoughts?
My final thought would be similar to Tracy's, just to caregivers, family members, love yourself. Love yourself enough to know that you deserve to live well, that you deserve to take advantage of resources that will help you along your journey. There's a scripture my aunt used to talk about all the time, that the people perish because of the lack of knowledge. We don't have to perish, none of us. We don't have to perish. So take advantage of any resource that's given to you. There's so much that's available. There's so many organizations out there that'll be helpful. If you don't know where to start, take my number down, call me, send an email, and I will help you start. So just love yourself.
And you'll say an amen to that, Tamika. Well, thank you very much, folks. Thank you for your willingness to hang in there with us. It was a very rich experience. I'm grateful to each of the presenters. What a deep dive that we did in a very short period of time on this important topic of hospice and palliative care services. I just wanted to let you know that our next workshop will focus on managing stressful caregiving situations and enhancing self-care for care partners of older adults with dementia. We have had a previous workshop on challenging caregiving situations, but we're going to take a deeper dive this time. We're going to cover issues that weren't addressed by Mrs. Vicki Rose in the first round in dealing with challenging caregiving situations, covering those topics that we didn't cover previously, such as challenges in encouraging loved ones in the early stages of the condition to take memory enhancing medications, having to adjust to, at times, refusals in taking those medications, how to deal with challenges around bathing and dealing with refusal to eat dinner or breakfast. We're going to cover a number of challenging situations that we didn't cover previously or didn't have time to cover in depth. So I thank you. You have a wonderful evening, and good night, and God bless.
Good night, everyone. God bless.